Good morning. This is Dr. Patwardhan, pediatric orthopedic surgeon from Sanchiti Institute, Pune, and I'm presenting to you our arm board technique for close reduction and pinning supracondylar fractures in children. We have no disclosures, there is no commercial support or any funding for this video. Conventionally, supracondylar fractures are reduced and pinned in the following positions: with the elbow on a hand table, where sometimes manipulation of the distal fragment becomes quite difficult, and after that pinning requires a free access around the elbow, and the table actually comes in your way and the drill keeps on hitting that while passing the KY, so it's quite tough. You can use another method where people keep the elbow on the C-arm tube itself, but the cleaning solutions can seep into the C-arm equipment and can damage equipment and cause problems. Some people do reduction and pinning in the lateral position, but getting an orientation of varus and valgus is quite difficult when the patient is in the lateral position. You need an assistant for traction, counter traction, and when you need to see the lateral view, you tend to externally rotate, which causes the reduction to slip. So we have our own way of doing this supracondylar reduction, which we will demonstrate. This is a preoperative radiograph of a type 3 supracondylar with a brachialis perforation and a pucker sign. That's the ecchymosis as it is seen. This is the picture of the arm board. It's simply a wooden board of about 1 inch thickness, which is radiolucent, painted with a simple oil paint, and is about 4 feet in length. Preoperatively, always check the capillary refill. Now the arm board is positioned thus that the proximal fragment is strapped with a transport or a hypoallergenic paper tape. The distal fragment is off the table, off the board, and with a gentle milking maneuver, we can reduce the fracture. You can see that pucker sign disappear, and you can see that the distal fragment is completely free and it's outside the board. I do an AP check and confirm my coronal plane alignment, and then we make the C-arm rotate by 180 degrees to look at the lateral profile. I don't need an assistant because the tape provides counter traction. I can reduce the fracture. I can check a true dead lateral in this position, and this allows me complete 360-degree access for pinning. After appropriate preparation, antiseptic lotions are applied and draping. The first pin is passed through the fossa in the lateral profile with the elbow flexed, maintaining my reduction. I pass the first pin from slightly anterior towards posterior, and that goes through the fossa, which is the forecortex pin. Then I turn the C-arm by 180 degrees to look at the AP, confirm the position of my pin, and the second pin is now placed parallel about 8 millimeters away from the first pin through the column. So we have a column pin and a fossa pin, and you can see the ease with which I can do the procedure without any real assistant or traction counter traction. I can then rotate in external rotation to confirm rotational stability, which you can see is very good. And then I take obliques, the internal and external oblique views, to look at column position. Then I bend the pins and cut the pins, leaving a centimeter out for extraction later comfortably. After which we remove the draping, and a cast in the comfortable position of about 70-degree flexion at the elbow is done, and always finish by checking the capillary refill post-operatively. Thus, the supracondylar pinning can be made very easy, and you can achieve consistently results like these extremely easily without any damage to equipment, without any assistant. We've been doing this method for over 15 years and I've had excellent results. In case of difficulty in reduction, joysticking is also possible with this, and we can just push the arm board a little further if I need to do an open reduction from the anterior approach. Thank you very much for your kind attention.